once we can evaluate that data and compare it to our set, it will shed light on why the patients that we have so much difficulty just with detoxification. Because literally in our patient population, about 83% on audit have SNPs in multiple pathways. So, and people ask me all the time, can I have implants and be fine? Well, sure. Yeah, if you detox well, yeah, of course, right? If you don't have a lot of problems, like there's a genetic profile that basically puts you at risk for not just this problem, but all sorts of chronic inflammatory problems. I don't think that takes a rocket scientist to figure out.
All right, Dr. Whitfield. So you're one of the only, I think actually for really the only surgeon in the United States and probably even worldwide that actually performs explants and fat transfer at the same time for breast implant illness or breast implant removal. And I want to talk a little bit about kind of how you got into this world. Why do we see breast implant illness anyway? Because I think a lot of people don't realize that this is still a thing. You and I have talked about this before, but particularly how you come about being able to do a method that most people don't even know exists. I think most women don't even realize if they're doing some sort of breast reconstruction after breast cancer or they've had implants and they want them removed or they have illness that they can even do a fat transfer. So tell me a little bit about, like, how did you get here and how did you get to the point where you do something no one else does?
Well, thanks for having me on, Dr. Murray. And I appreciate that because it's a conversation that's not had with patients when they first get augmentation. Many patients who come to me who explant, and I say, well, did you ever have the option of fat transfer explained here? And many of them say no. Now, you have to qualify by many of those patients were low BMI to begin with, and that's why they got an augmentation. So not everybody is a candidate, right? You have to have body fat in order to do a fat transfer. So when I'm seeing patients later in life, and we'll say, 30 to 55 is kind of the bigger area of the group that I see. Many patients have had children already. Many patients are perimenopausal or menopausal, and they've gained weight. Now, sometimes what I try to do, Dr. Murray, is I ask everyone to get something that's usually readily available in their communities, which is a DEXA scan, DEXA scan. Now, I'm not getting it for bone density, although with the abuse of GLP-1s, I now feel it's incredibly important to have a baseline. And it's really, we can talk about that, as well. It's a frustrating thing for me to have patients on drugs that affect bone density in my patient population without any baseline. So I'm looking for fat. Where is it distributed? We're looking at the abdomen, of course, the love handle area, the inner outer thigh areas. Those are the most frequently accessed areas that we would use for fat. But as you would expect, patients don't want to have an explant and aesthetically be affected. So I try to do as many simultaneous transfers as possible. But you and I both know that if you don't prepare the patients properly, the chances of success or the efficacy or the outcomes are going to be more variable. So there's a great paper that I refer to, and I always thought about this in my mind, Dr. Murray, like, okay, if all things being equal, if you just transfer your own genetic material to the right place, in the right space, at the right time, it should work, right? That's how transplants work. So autologous, which is what we're doing, is transferring your own fat to the space behind the skin above the breast tissue. So that's where the fat lives. It doesn't live in the breast and it doesn't live where the implant was. Many patients ask why I do it at the same time, just like you pointed out. And there are a lot of folks concerned about toxins. Toxins get stored in fat. So we look at a Vibrant Wellness Total Tox test pre-op on all of our patients who are having fat transfers and all of our patients having explant, because we run a whole program based on my book, The Sharp Method, to really prepare patients in the most holistic way possible pre-op so that there's not as many of these things that we have to deal with post-op. Fat transfers should work, really, really well. I just shot some footage about hyperbaric oxygen therapy for improvement in fat transfers. And we have lymphatic massage from New Zealand with the Flopresso and red light therapy and nano-V therapy and all sorts of other therapies I probably can't remember in my office. But just in general, that should work. Your own genetic material should work well when you're prepared properly.
So I would assume, obviously, if somebody's going to really any surgery, because I'm going to ask about personal things in just a second. But if you've already got trauma from the surgery, right? You've got trauma from the explant because the explant was infected and all these other things. And if somebody doesn't do that preparation, I'm assuming you could get necrotic fat tissue and other things if they aren't really prepared to do a fat transfer, or even if they're, not doing that, even if they were doing some other method, if they haven't really done the pre-op prep, it's not going to come out as well as if they did.
Yeah, I think being prepared, and we didn't talk about all the different factors. Obviously, there's emotional factors as well that go into this, and working on yourself is principally and paramount. One of the things that I find difficult to get patients to do, as I imagine you do as well. And then we prioritize obviously sleep and nutrition and quality of food and fluid intake. And when you start stacking all of those changes, then you'll get a big difference, right? Those tiny habitual changes will amount to a very large change in your not just your well-being, but in your preparation leading up to any surgical procedure. And so the SHARP method works for whatever surgical procedure you want to run. And we talk about cosmetic surgery because that would be the next most logical place where people want to obviously get prepared and recover as fast as possible. And then regenerative medicine space, cosmetic dentistry, orthopedic surgery always comes to mind because of my close association and work I've done with orthopedics. But you can really spread it across any surgical discipline.
Yeah, I mean, looking at it personally, I think you and I've talked because you and I know each other, we're friends, and I have to have a hip replacement, but I also have torn like my gluteus medius, my gluteus minimus, my hamstring tendon. So it's like it's a lot more than just a hip replacement. Like I had
Right.
done full labral tear, and I was like, I got to talk to Robert before I do this because I got to make sure I'm doing the right thing to recover. Because even picking my surgeon, I know people come from all over the world to see you, right? Your surgeon matters, right? Like I waited to talk to this guy that I'm seeing for 6 months because he's one of the best of the best. And I was like, I want somebody to look at me like an athlete, not a woman. And he's like, you'll still be all right because you're in your 50s. Like that's important.
Right. Right. Yeah. This is operation, the game, so to speak, operation is better if, in fact, you've had a lot of repetitions at that game.
Yeah.
If you don't have a lot of repetitions, surgery is not the sport for you.
Yeah.
You should move on. So
Yeah.
waiting does matter. I mean, I'm speaking to someone from Australia later today, I believe. And, we have patients, that, do come from all over the world now. And it's very, you know, I'm, I'm very proud of that. Our team is excellent. Our stack is great. And, basically the patients who come, they're trying to get a different level of experience, just like you're describing, right? There's a level of surgical experience, there's a level of clinical experience, there's a level of team experience, and at every level of the organization, we have really you know drilled that into the team, so to speak. And whether it's, I have my own tech who's done thousands of cases with me, and we're opening our own surgery center here shortly, like we've talked about offline, to better improve the patient experiences and the surgeon's experiences, as well as, all the things we have in the office that I mentioned before, the human regenerator, the hyperbaric chamber that's vertical, so nobody has to, crouch down. Just like, for you wouldn't want to like lie down in a chamber after a hip transplant or hip replacement. I'm sorry. That would be awkward, versus just stepping in and sitting. Should be fine, right? There shouldn't be an issue with that. We try to think carefully about and intentionally about what the patients have to experience and go through. It's, coming and spending a week in Austin is the minimum commitment for in the United States. And out of the United States, I've had people stay minimum of a couple weeks. I've had people stay a couple months and everything in between, just so that they can take advantage of all the things we have in the clinic.
Yeah, yeah. So let's talk a little bit about this because if anything, the women that listen to Menopause Mastery, I tell everybody we associate, or at least this is my perception, and I know this is how I see it. I relate to J Lo aging. When people are like, whenever you ask AI, and I was like, "Give me a woman in midlife," and they show somebody that looks like, one of the Golden Girls, that shit pisses me off. I'm like, "I don't relate to that." I mean, I'm just being real. Like, I don't relate to that. I do not I do not feel like I feel really great at 56. And I want to look that way. So even like cosmetically and other things, all those things are on the table for a lot of my listeners. And so let's talk about your sharp method in particular. So if a woman is thinking about cosmetic surgery or like me, orthopedic or anything else, or if they just want to feel better, this method is a way to prepare as if they were preparing for surgery. So tell me what sharp stands for.
Yeah, strategic, holistic, accelerated recovery program. So the way I was taught was you need a chest X-ray to look and make sure somebody doesn't have, pneumonia or there's not something we're missing that's big that's going to hurt them. An EKG, so we make sure everybody's got a normal, cardiac rhythm, basic blood work to make sure somebody's not anemic, and then electrolytes to make sure somebody doesn't have a really elevated potassium level, which could, potentially harm them while they were under anesthesia or when they were given, certain drugs. And so that's how I was taught circa 92 to 96 for med school, 96 to 2002 for surgical training, '02 to '04 for plastic surgery training, and so on and so forth. But now I don't do really any of that. I make some kind of basic assumptions, and I hope you don't have a pneumonia. I hope you don't have a cardiac problem. Now, all those things have to be worked up before, you're ever going to come see us. Um, when people, maybe this happens to you, but people all the time will say, I feel like I have palpitations. Well, if you say that, you're going to have to get that evaluated because I'm a plastic surgeon, not a cardiologist. So you need to get that checked out. That could be from a number of reasons why you feel that way. Anything, from anxiety to an electrolyte abnormality. So, just get it checked out.
One, it's a really common symptom with menopause. Right? So I'm like, if you're not on estrogen, girl, you gotta be on if you're not on hormones, chances are you could get what sounds like and feels like heart palpitations and is, but it's related to the lack of estrogen. Now, I'm just curious before we go kind of into your deeper thing, you probably recommend your patients, depending on where they're at, if they can be on hormones, they should be, because estrogen helps collagen and elastin and all those other things too.
Yeah, and I'm glad finally the powers that be finally took the black box off of estrogen. So basically, the way we did it, and because I have patients come from around the world or around the United States, I don't manage their estrogen. I want that, done. That's more nuanced, as you know. Now, the way we work people up is looking at their functional genetics. So, like detox pathways that are genetic. Look at a tox test to see, like, what is their level of a mycotoxin. So, mycotoxin, if we can just go there, is that's what comes from mold. And there's a whole list of these things. Aflatoxins can be found in nuts, and Zen can be found in coffee, and so on and so forth. And that's very common, in addition to your ochratoxin from black mold, which can be found in wine. It can be found in your, bathroom, in the shower, whatever. So all those things affect each of us very differently. They may not affect Dr. Murray at all, but I know I get really sick if I get exposed to black mold. I just don't detox it well. So that along with, and we do a gut test, although, Dr. Murray and I have talked about this, man, those are really challenging. And I've done, as a plastic surgeon, I think way too many gut tests personally. But we've settled on the gut zoomer now. And then we do look at blood work mostly for just balance, not, can't have anybody anemic, of course. And and I have a bunch of folks who have parasitic problems just like you do in your practice. And so those have to be addressed. The thing we do always add and look at, as Dr. Murray was alluding to, is hormones. So if I have somebody come in who's completely out of whack, they need to get that addressed. We used to do quite a bit more temporary testosterone balancing because testosterone is such a necessary hormone for recovery. we would add that a lot, but based on certain things at the centers we've been working at, we can't use that currently. So we do it in the offices. Um, Now, that all being said, you heard the last thing I did was look at somebody's blood work. It wasn't the first thing I did because that's not really where you're going to find most of the problems and the things that you need to look at. So we'll take our fat transfer patient who's coming from, we'll say, Florida. Florida's got tons of trouble in terms of mold from the moisture, the natural disasters of flooding and hurricanes and all the things there. So if I have somebody, which this happens pretty routinely, who wants simultaneous fat transfer, they'll call up and say, okay, and we'll get their test and it'll come back and it'll have a whole litany of, mycotoxins in it. And, just like you, Dr. Murray, I have to sit there and go, okay, now you're not a good candidate for this. So that being said, the things to do are to go through a protocol. And there's lots of them. I'll give you how we think about it. We utilize hyperbaric oxygen pre-op. So for everybody listening, hyperbaric oxygen increases the level of oxygen in the tissues. So tissues that are hypoxic or have low oxygen levels are where infections or we'll just say, problems lie. So increase in oxygen level tensions always improves those, tissues. Secondarily, we put people on something medically that's an antifungal. So there's antibiotics that treat bacterial infections and antifungals that treat fungal infections. We treat these with itraconazole typically, and then we also use a medical grade binder and basically cholestyramine because the mycotoxin binds to the bile acid and your body wants to resorb the bile acid, doesn't want to lose it. That's part of the intrahepatic circulation. So and Dr. Murray's got a PhD in the gut. She knows all about this. So anyway, you have to take that out. If you just treat somebody but don't take that out, you're not going to eliminate it unless, you're super fortunate, which my patients are not on the super fortunate side almost ever.
Yeah,
So
I
that's
joke
how
that
we
that's my
start.
lotto. Yeah, I won that
Right.
lotto. I don't do those well.
And then, we like to repeat that test and make sure those levels are coming down. And then we adjust based on that. There are always other homeopathics that you can use or pretty aggressive with that upfront protocol. And then if everything's going according to plan, they're dropping their levels, we can proceed with, the procedure. And afterwards, I've had people have the best results by staying very aggressive in that protocol afterwards, especially as it relates to hyperbaric oxygen therapy. Once again, after, right? So surgery decreases blood flow. It doesn't increase blood flow. The only surgical procedure that increases blood flow is cardiac surgery, where they revascularize because there's a blockage. That improves physiology. There is no other surgery that does that outside of that, procedure. So everything else causes, hypoxia or decreased oxygen levels in the tissues. So if you typically operate Tuesday, Thursday, the day after, everybody comes here for hyperbaric therapy. So they'll get that, they'll get red light, they'll get some lymphatic massage with nano-V therapy, and they'll get the human regenerator, which helps decrease their sympathetic activation because everybody's cortisol is way up, right? Rob's the number one producer of cortisol in the world because he operates on people for a living. So I cause cortisol dysregulation basically for a living. After that, you got to keep your nutritional support up. There's all this like kind of waxing and waning about I'm going to get big and bulky if I eat proteins. Weird. I don't know where that came from. The other thing is the most recent studies that you can like look at and really glean something from show that if your BMI drops a point, your fat transfer result may suffer up to, 50 to 60 to 70% loss. If you can keep your BMI at the level it was pre-op, remember I use a DEXA scan, so it's not easy to, fool the DEXA if you put in the weight properly. You can't fool if you put in the weight right. Um, Afterwards, if you can keep it level or go up a point or two, you can keep almost 80%. So I used to, and I still espouse the same thing. This is not a technical challenge, Dr. Murray. It's a behavioral challenge on the patient side. There's a lot of work that goes into it for them and to maintain it. And people ask me if this is going to last. Well, you do perimenopause and menopause for a living. Everything is going to change,
Right.
unless I freeze you the day after I do it. It's all going to change over time. So let's just be realistic about expectations. And I'm very transparent about that. I don't overpromise anything. I can do the exercise of acquiring fat, processing fat, and placing fat back in the correct, places with the proper preparation. And then the patient needs to heal that and maintain that level of, we'll just call it, well-being, as it relates to nutrition and sleep and quality of food and fluid intake, but maintaining the BMI. So I really discourage, and you can argue with me about it, but I do not like HIIT or interval or cycling or running as a way to maintain a fat transfer result. In fact, if you do any of those things, I tell you, you're not a candidate for that procedure, because that's the polar opposite of what I need you to do. And what you should be doing as a perimenopausal or postmenopausal or menopausal woman, which is maintain strength, increase muscle mass, and add healthy fats into your diet. Those are like core things that it's somehow like uh, going over everybody's head.
Ladies, if you're noticing more fine lines and wrinkles, it's not just about aging, it's about the loss of estrogen. And that affects our skin structure, making it drier, thinner, less firm. But here's the great news: I've created Biased Mastery Cream to help. This luxurious bioidentical estrogen cream supports your natural hydration and elasticity. It's packed with nourishing oils like olive, jojoba, aloe, and coconut, so it feels amazing and helps soften those lines and bring back that healthy glow. I've been using it, and let me tell you, my skin has never looked or felt better. It's smoother, more radiant, and those little cracks and creases are way less noticeable. If you're ready to give your skin some extra love, check out By Est Mastery on the Metabolic Blueprint website. And that's metabolicblueprint.com/Biest Mastery. That's BIEST Mastery, MASTERY. And your face will thank you.
So I want to make sure we hit this point really, really clearly. If a woman is doing a fat transfer because of a breast explant, or maybe she wants augmentation,
Cosmetically, yeah.
cosmetically, and she wants to use fat transfer, BMI, which is body mass index, you need to maintain the body fat to muscle mass composition at where you were, or improve it by not losing that BMI. So you don't want to get below it. So with the Ozempic and GLP, GIP, triple G, retraditide and all that stuff, this freaks me out because everybody is now doing skinny talk. Like we had a few moments there where there was a little bit more like, hey, there's different bodies in the world. And now everybody's like, dude, I'm going to do the shots and get super skinny again. Well, what that means is if you're a woman that's had a fat transfer, you will lose your breast material, your fat, because it's going to come off of there. I never had that, right? I don't lose, like I had to get mine reduced and put back where God wanted them to be. But they're going to lose what they just went through getting. Like, that's really important.
This has already happened to me. I've had people, this microdosing bullshit. There is no microdose. There's a dose. That's what's approved. When you quote unquote microdose with a compounded drug, there are a lot of variables there you don't really understand, right? One, you got it off the internet typically. There's no QA. There's no quality of that. So quality control. So you could have a elevated dose or low dose. And if you interview people as you have, you'll hear, oh, this vial was different than the other vial. And my favorite is one patient recently said, oh, and sometimes if there's more in the vial, I just increase the dose, like leftover.
Yeah.
And I said, oh, I'm just curious. If that was a heart medication, would you increase the dose just randomly like that?
Yeah.
And they, of course, look at you and go, no, I know that's wrong. But
Yeah, they're
intrinsically,
not
because
benign.
it's fat, they think this is okay to destroy. And it's really not. I've had patients patients that are very prominent, high profile people give themselves facial fat atrophy. And I can't fix facial fat atrophy in patients, not because, you know, there's not a solution for that. But when you're taking that drug and the solution is to put fat back, so you got fat, you got a foreign substance, which I basically avoid putting foreign things in people. It's not part of my program, but it's going to create a bunch of funny looking people
Yeah. Oh my goodness. Yeah. So
or prematurely aged people would be the better way
yeah, because
to
that's
describe it.
I mean, I don't know about you, but I get all these Instagram ads because I obviously own a clinic, and then I've got my telemedicine company doing hormone replacement, and now I'm getting ads on Instagram about devices that help with skin tightening because of the GLP craze. Like, that is the marketing message. Like, people are gonna have slack skin because they lose weight too quickly, and then, like you said, on your face, facial atrophy, like, that I would assume that would look scarred and God knows what, right?
It just looks drawn in. It looks prematurely aged. And especially around someone's mouth. You can take somebody who is naturally very beautiful with high cheekbones, and they misinterpret their vision in the mirror as being somebody who's maybe fuller faced or round, and they're really not. And then when they use that drug, and everybody listening needs to understand, those all work. They all work, and the ones coming work way better than the ones that started. So the efficiency with which these things are going to creep up to, I think one recent one was 34% effective on fat reduction. I mean, that's just shocking.
Yeah, that one's
So,
on its way out, yeah, to the market.
I mean, when that comes out, I mean, I have a very strict policy of patients, like within 6 months, any procedure, they can't be, taking the GLP-1. And the thing is, uh, there's not a good way, like, to check. So we have no idea before or after what they're actually doing. And it's a frustrating thing because, there's only so many avenues I have to, get people really prepared properly and then go through a procedure and then rely on them to, make these modifications in, lifestyle and behavior and maintain these results. And then somebody a year and a half later will go on and write some crazy stuff about me on the internet. And I'm like, oh, okay. So that day I forgot how to do what I know how to do. I find that hard to believe.
Yeah, I mean, I think the accessibility, particularly of the compounded forms online where people can just order and buy whatever, like, you have no idea what that stuff is, Could be bacteriostatic water all by itself, and that's it, and you just paid $200 for the vial.
Or
It is kinda
worse, it's actually
something
three
else.
times as strong as it should be.
Right, true, yeah, because there's no control over it. Well, and I think about it, like you said, whether it's breast implant illness and they're getting an explant or particularly cosmetics, because that definitely comes up in my age group because we start, picking apart what we don't like. As you want your best possible outcome. I mean, really honestly, and why undo all of that work that you went to the best surgeon for and had the best experience for? By chasing some sort of extreme that happens to be the aesthetic today on TikTok and Instagram.
Right.
Like,
Oh, yeah.
it's just a mess. So we talked a lot about kind of the sharp method and preparing. And then, as somebody comes out of surgery, so like hyperbaric, obviously great for oxygenating the tissues and helping, particularly like in my case, orthopedic surgery. Like there's a lot of risk for infection. It's terrible. It's terrible. Blood flow to the bone, hyperbaric would be extraordinary, right?
Yes, for you, that would be something that, especially with a vertical chamber like we have, I had people ask me how many times a week. And the old studies, if you look at how aggressively they treated like diabetic foot ulcers, the kind of worst possible scenarios, I mean, those are literally like 5 days a week. Well, okay, let's be realistic. 2 to 3 times a week is adjunct, and that's how I view it, right? I mean, it'd be great to, have the ability to stick every person in there an hour a day. Okay, well, let's let's be realistic. So I try to get people to do 2 to 3 times a week. Like it's a lot to just come back and forth and spend, a couple hours at a clinic.
Yeah,
So,
for sure.
especially with you as busy as you are.
I know. I have toys in my house and I don't always get to use them. Okay, so for someone else that might be going through surgery, what would you say are the top things from your SHARP method that they should think about to help make sure that their recovery is best?
I feel those baseline tests we mentioned, so genetic tests, understand your genetics, understand your toxicity burden. That's going to change too. Like, and these are all giving you like Kodak moments. And a gut test, similarly, as you know, a Kodak moment, especially depending on how the method of evaluation is used, and food sensitivities and hormone balance. Like, it's one of those things where you're trying to craft as big of a broad of a picture as you can at one time to help patients better understand, what's happening, because blood work is blood work. It hasn't changed really since the 50s to me. I mean, there may be some more biomarkers, obviously, but is it really that dramatically different? I mean, overall, I don't make a ton of clinical decision making off of blood work. I mean, I look and see if someone's anemic. And for that matter, like there's this great, post the other day I saw, like, okay, so in oncology, what is the most important aspect of a blood count? It's lymphocyte count, but it's also the one that nobody actually pays attention to because there's no drug to affect it.
Right.
Right? You can't take Neupogen or Epogen or any of these other drugs to affect those cell counts, but the natural killer cell count of the lymphocytes is what actually protects you from cancer. So if you could just augment that, there wouldn't be, quote unquote, we'll say cancer. But
Yeah.
that's not got a drug. And so not really an advantage there. So, we try to be as deliberate and intentional about explaining, all right, here's your genetics. So maybe you don't have a really good glucuronidation pathway. Maybe you don't have a good methylation pathway. Everybody's heard of, I hope, of MTHFR at this point. It's become like, part of the vernacular, so to speak, but it's just one of many methylation genes. And the antioxidant pathway ran by, SOD2. If someone has tons and tons of fatigue, they usually have a pretty poor SOD2, pathway in our experience. And then for immunity, the vitamin D pathway, it's, constantly a problem with our patients is the majority, if not like all of my patients, basically have a poor vitamin D pathway. They either have mutations in GPX or VDR. So those are just, our going from, activated to absorbed and all the different things we, deal with vitamin D. And it explains a lot why people have just chronically low levels because it doesn't, you can get all the sunlight in the world and then not be able to utilize your vitamin D. So like there's a lot of like basic things that, we could be doing better with as, groups of providers explain to the patients because they're out there typing the stuff into whatever AI, thing that they use, whether it's chat or Gemini or Claude or whatever. And, that's still not clinical experience, but, and, I'm glad we brought this up. So we have an IRB to look at our patients' genetics versus the Welderly study done by Eric Topol, because they lived to the, I want to say, seventh, eighth, ninth decades without any evidence of chronic disease. So no like kidney disease, lung disease, Alzheimer's, cardiac. And so I'm sure you would hypothesize that those folks detox well, in addition to probably not participating in a lot of things that would affect them. But I feel like, once we can, evaluate that data and compare it to our set, it will shed light on why the patients, that we have so much difficulty just with detoxification, because literally in our patient population, about 83% on audit have SNPs in multiple pathways, the ones I mentioned previously. So and people ask me all the time, Betty, can I have implants and be fine? Well, sure. Yeah, if you detox well, yeah, of course, right? If you don't have a lot of problems, that's basically what we're talking about. Like, there's a genetic profile that basically puts you at risk for not just this problem, but all sorts of chronic inflammatory problems. I don't think that takes a rocket scientist to figure out.
Absolutely. I can't wait to see the outcome of that study. It's part of the reason why we're building the Minerva technology platform is to democratize women's health and allow women to capture their own data. But it's also to do comparison studies against data like that because, why is it some women get breast cancer? Why is it some women get autoimmunity like Alzheimer's, dementia, cardiovascular? All those things have to do with how we are genetically predisposed. And then obviously the environment is the big trigger, but we just don't have good data. And I had an argument with a clinician the other day that was like, "Well, we don't have data on that, so we're not gonna do it." I'm like, "Well, you can't get data if you don't look. So at some point, somebody has to, like, woman up and do the work, right? Instead of waiting for it to happen in some sort of gray area, because we haven't studied women in 22 years, especially around hormones, because we quit treating with them, right? So yeah, I'm excited to look at that because I think that kind of data will help us then understand how to individualize medicine for women.
Well,
So
we published the study last year.
yeah.
Oh gosh, now it's September of 24 because we've
Yeah.
moved on to a new year.
Yeah.
That showed that in our, female patients, that when you explant them, the scar tissue has 29% bacterial contamination. So whether you feel like that's a frank infection or not, both Dr. Murray and I know that the actual data on infections was done with urinary tract infections, and it was done in the 50s.
Yeah.
So I get a little put off by, people who are rigid about that kind of data. So since 2019, we've only looked at PCR data on our explant specimen scar tissue capsules because although it's not, um, the RNA data, which shows you like what's alive at that time, the DNA data shows you what's there. So even if it's very, very small amounts, it just takes one copy to be there. So I trust science. I believe that that is currently the best methodology to show me what is there. So if I explant somebody and that PCR data is positive, we don't treat anybody with antibiotics. I treat it as, oh, okay, well, this was a patient who clearly had this amount of immune system activation because the bacterial biofilm, can interact with the fatty acid in the breast called oleic acid. That fatty acid oxidizes and becomes, because of oxidation, oxylipin. The fatty acid's a lipid. So oxylipin 10 home has been studied and been shown to be in elevated amounts in patients with more symptoms of chronic inflammation who have underwent explant. So, okay, so you have biofilm, you have an oxidized fatty acid. Ultimately, that leads to macrophage polarization and increased symptoms. Okay, so that's a cause and effect, pathway. And if you have a genetic predisposition and you have that problem, well, I'll go as far as to say as I presume you have more symptoms. The final and more interesting component was published recently in a paper out of Denmark and showed that the scar tissue around the implant that the patient produces is acting in a way like it's rejecting an organ.
Mm.
So it's increasing not just a T cell response, which is normal,
Yeah.
it's causing a B cell response and a plasma cell response.
Okay.
So if I were to donate a kidney to Betty and our blood types match, that would be the first level of match. The
Right.
second would be the HLA match. And if it was a
Yes.
negative cross match, then she could have the kidney, but she would need drugs to prevent what I just said
Yeah, like a cell sub kind of anti-rejection
because
drug.
you're going to create antibody, you're going to create a rejection. And that is what they're seeing now. And so that, imagine someday I can do an RNA test because that's a transcriptome test. They're looking at
Yes.
RNA.
Yeah.
And so if I could just send off a piece of tissue and get an RNA transcriptome analysis, wouldn't that be nice? Wouldn't I
That'd be
know?
amazing.
Yeah, I mean, though, that's why I just like molecular techniques are probably, you know, and should be utilized more and more and more. But like, we're still stuck with like people, using Q-tips and swabbing stuff. I mean, it is kind of ridiculous, but that is just the nature of people don't move on, they don't adapt. There's all sorts of reasons why, but I find it super, frustrating when these things are, brought forth and really interesting, types of studies now that are being done. And I often say, like, I went back and I looked at all the papers about capsular contracture, which is tightness or firmness of the scar around the device. It was really common when it was above the muscle. And that was where implants were first placed in 1962 by Cronin and Giroux in Houston. And so when they do that, nobody understands why. They're using like steroids, they're using antibiotic solutions, they're trying to get this capsule to stop forming, it won't stop. And then magically it goes down, the capsular contracture rate goes down when they put it behind the muscle. Now, Dr. Murray, I'm pretty convinced as I think about it, and as we discussed, that really didn't change how scar forms. It just changed how you can examine something. So it's like a sleight of hand maneuver, right? We just put the device behind more tissue, which made it harder to feel by me and harder for you to tell me that, ugh, it's tight, it hurts because it's not closer to tissues that you can now compress and feel easily. And when I take these things out, I see how tight and firm they are. And I'm like, man, this is surprisingly thick or tight or hard to deal with because you can't tell on exam because the muscles over it,
Yeah,
the breast tissues over
you
it,
can't
the
palpate
fatty
it.
layer. Yeah, it's very hard to examine. So, and when I reviewed all of this for a show that I didn't release yet about capsulectomy, and I was just like, yeah, I don't think this has anything to do with a decrease in the actual rate. It just makes it more difficult for the patients to tell us there's a problem and for us to examine and determine there's a problem on their exam. So
So let me see if I can I'm gonna see if I can take that and sort of capsulate for everybody. So obviously you've been looking in the capsule, right? In the biofilms that are available from the infectious activity that you find in breast implant. You're using PCR, which identifies is a bacteria or fungus or something present, right? And for everybody, that's our current level of technology that's accessible commercially. The next one would be RNA, which is then what are they up to? What are they doing? Right? If we have bacteria present that aren't supposed to be present, especially infectious bacteria, fungus, and viruses and things like that, that's going to create infectious activity that then establishes innate and adaptive immune cell response. And then your body is going to create scar tissue, encapsulate it, and then there we go. And then we got an inflammatory response that's not only inflammatory, but initiating immune response constantly. And this is really the trajectory of breast implant illness. And we wouldn't be able to palpate it because it's under the muscle because that's our current technology to do implants. Is that a pretty good sort of summation in real words for people?
yeah, I want to say I'll add that when people take implants out and they don't remove the capsule, especially as I think about it, the debris or the remnants of the materials in the capsule that could be left in the tissue are ongoing sources of immune system activation.
They leave the capsule in?
Yeah, so the scar tissue capsule is left in now because I feel it doesn't resolve, not in my opinion, but this has been espoused by others that it's not necessary. So I think, from listening to our discussion, obviously, my stance, it is necessary because basically 29% have bacterial contamination. So you wouldn't know that, that's an after the fact determination. And then two, now your T cell has a receptor. Any of that material, which obviously is not your tissue, is going to cause a response. And your immune system is very effective at mounting a response. And so I've had patients who've had their implants removed contact us and say their symptoms didn't resolve. Well, I don't think it takes much to figure out why that didn't happen. So if 30, we'll say 29% have bacterial contamination. So you're not removing that.
Yeah, because the tissue's still in there.
The tissue's there. And technically, if you think about bacterial biofilm, which is like plaque on your teeth,
Yeah.
it's not very easy to remove.
No.
So that's one problem. Two, if there's debris or rupture or gel bleed, or we'll just say any contamination from the actual device of the shell, configuration or the gel or whatever, you're going to have a T cell response to that.
100%.
The arguments about not doing capsulectomy to me make very little logical sense. And I mean, you could argue all day long with me, and I'd still think what I just said is the more logical way to think about it from a microbiology standpoint and from a T cell activation standpoint with a foreign body exposure. So those things, kind of lead me to always do a capsulectomy. And obviously, there's different types of capsulectomy. You'll hear about, when you type in the internet, there'll be en bloc. En bloc is a pathology term, for tumor extirpation or removal, and that's with a margin. People get very, animated about this from a society level. And so basically, I just tell everybody, we're doing a capsulectomy. We want to take it out intact, if at all possible, because of the aforementioned bacterial biofilm, any kind of, rupture or leak. And many times I don't even find things out or ruptured until after the case is over and we're examining things on the back table, because I'm not opening things during the case to see what's going on. I'm trying to get them all out and get the patient taken care of. So those are the reasons why I always promote doing a safe capsulectomy. People say it's dangerous. It's not dangerous. Oh my gosh. So taking out scar tissue has been done all throughout surgery. So, people say you're going to cause a lung injury. No, that's not a problem. In fact, JJ Watt, the guy who plays for Pittsburgh, he got a dry needle injury to his lung, and that's why he couldn't play for a while. And that's with the little needle. So that actually poked a hole in his lung, and that was the problem. So we don't do that. Anybody who operates understands that. And you shouldn't fearmonger a patient, because it is safe to remove the scar tissue. You can do it effectively and relatively smoothly. I've done several thousand of these cases. It's not a big deal. We published a big experience of 600 and, oh gosh, 90 some ish patients for the study, and do, whatever, anywhere upwards of 6 or 8 a week. So, pretty normal for us.
Yeah. I mean, to me, it seems crazy that there would be an argument to not remove the capsule. Like anytime, like in general surgery, if somebody's going in and, like a really good example, endometriosis tissue, right, leaves a lot of scarring. And if somebody does repeated tissue, part of the process is to remove some of that scar tissue when possible so it doesn't exacerbate the problems, So I was
Yeah.
like, to me, that just seems crazy that we were like, oh, let's just leave that in there because, it's behind the muscle and you can't really feel it. I don't know, that's crazy. So you have a book out about the Sharp method, right? And you have
Yeah.
capacity for people to kind of, whether they're getting plastic surgery, explant surgery, or in my case, orthopedic, or they're preparing, or they're doing anything where they're going to need recovery. That whole method goes through how to prepare and then how to kind of take care of yourself on the backside. And that is out right now, so we can get it in bookstores or online.
Yeah, it's
Cool.
available online and bookstores. And the point being is, we have an advanced recovery. Like patients always try to figure out ways to recover better. Regardless of what I say, you would go out and say, all right, I'm going to take these um, supplements, or I'm going to try these changes in habits, or I'm going to do X, whatever X is. And maybe it's from another provider's guidance or from a friend who experienced the same thing. So what we've tried to do is really level the playing field, explain it as simply as possible through, your genetics dictate how you detox. Look at your toxicity burden, look at your gut health, your food sensitivities, your hormone balance, your blood work, of course. And then you have a better understanding of where you're starting from versus, oh, I go through surgery, I stay swollen longer, I feel really run down longer. I'm not really, recovering like my friends do or loved ones have. Like, why am I different? Well, everybody's biologically different, right? Unless you have a identical twin, you're still going to be different genetically. So that's the difference, right? Dr. Murray, Joseph Murray did the first kidney transplant between identical twins. And they did it by first transplanting a piece of skin because skin is very immunogenic. And the skin did not get rejected. So they're like, oh, we can go ahead and do a kidney transplant, of which the transplant technically is not difficult. Obviously, Dr. Murray became a plastic surgeon actually afterwards and hooked up the artery and the vein in the ureter, and it worked for over a year. Patient passed away from other problems, and then the next step was to provide a level of immunosuppression when they did cadaver kidneys, of course, and that's azathioprine and prednisone, and that's really how transplant came to be. So when I think about autologous transfer of fat, I always think back to Dr. Murray showing that obviously if you transfer the same genetic material, which in an identical twin it is, it should heal properly, given the factors we've discussed.
Yeah, absolutely. Absolutely. Well, Dr. Whitfield, man, you helped you helped elucidate a whole bunch of just different steps people could take to improve surgical outcomes. And then obviously a little deeper dive in kind of breast implant illness for my listeners, that may I think a lot of women in my age group had them put in years ago for
Yeah,
aesthetic reasons. And now they're like, I think this might
sure.
be part of my problem. So thank you so much.
Especially in your area of Dallas.
Yeah, we like augmentation. We do. We do, and I mean, and I'm honest, I get stuff done to my face, like, I have Botox, like, I wouldn't I look angry without it, but, yes, we have to think about those things and what the impact may be, so I totally get it. So, thank you, Dr. Whitfield, for being on with me today and educating
Thanks for
my,
having me.
population, so thank you, everybody, for listening or watching to Menopause Mastery, of course, on YouTube or on your favorite podcast station, and then we will be back next week.